Acne is no longer strictly an adolescent disease. For a growing demographic of women over the age of 25, it presents as a distinct chronic condition, requiring a completely different approach to clinical management. The primary clinical presentation of adult female acne, or AFA, is highly specific. It typically emerges as deep inflammatory papules and nodules distributed in a U-shape across the lower third of the face, concentrating along the submandibular jawline. Because this presentation differs structurally from teenage acne, clinicians utilize the Adult Female Acne Scoring Tool, or AFAST scale, to accurately quantify the severity of these specific submandibular lesions. When presented with these severe, deep-seated lesions, patients frequently report clear hormone-driven symptomology, such as intense premenstrual flares. Yet, when clinicians order standard systemic endocrinology panels, the androgen levels almost always return completely normal. This is the central paradox of AFA. If you rely on systemic blood circulation to diagnose hormonal imbalances, you will miss the disease. The pathology is not happening systemically, it is happening entirely at the localized cellular level. To find the root cause, we have to look past the circulatory system and focus directly on the local microenvironment of the pilosebaceous unit. The sebaceous gland is not a passive victim of hormones floating through the bloodstream. It operates as an active, independent neuroendocrine organ. It contains the complete enzymatic machinery required to manufacture and metabolize its own hormones. The lesions seen in AFA are driven by localized enzymatic hyperactivity right inside this specific tissue, rather than a systemic overproduction of hormones originating from the ovaries or the adrenal glands. Effectively treating this condition requires intercepting the local microenvironment of the sebocyte. Attempting to suppress systemic endocrine function is treating the wrong target. SDHEA prehormones cross the cellular membrane into the sebocyte. Inside, 5-alpha reductase converts SDHEA into testosterone, then immediately into highly potent DHT. This DHT binds to local receptors, triggering a massive surge in sebum production and rapid cell proliferation. Inside the cell, there is a severe biochemical storm of androgenic activity, but in the adjacent bloodstream, just micrometers away, the hormone levels remain perfectly balanced. Because this entire androgenic conversion loop happens intracellularly, standard systemic hormone blood draws are functionally blind to the root cause of the disease. While the sebocyte overproduces lipids, a parallel pathology occurs along the follicular wall. The resident bacteria, Cutibacterium acnes, has historically been viewed as a simple infection. In AFA, it acts as a direct trigger for the innate immune system. Specific molecular patterns on C. acnes dock directly into toll-like receptors 2 and 4 on the host's keratinocytes. This activates a rapid intracellular cascade. The signal travels to the nucleus, triggering an immediate release of pro-inflammatory cytokines, most notably interleukin-1 alpha. Simultaneously, this same pathway commands the cell to release matrix metalloproteinases, or MMPs. These enzymes actively dissolve and degrade the dermal extracellular matrix. This severe inflammatory cascade and structural matrix degradation happens within invisible subclinical microcomedones long before a clinical lesion ever becomes visible on the skin. If a clinician waits for a visible papule to begin treatment, permanent matrix degradation and scarring are already underway. You must modulate the immune response early, directly at the receptor level. These localized biochemical pathways do not operate in a vacuum. Specific environmental and metabolic factors act as exact chemical catalysts, supercharging the pathology. This etiopathogenic map illustrates how external inputs drive the disease. Diet, stress, and smoking all push inward, accelerating the central mechanisms of acne. A diet heavy in dairy and high glycemic loads directly elevates systemic insulin and IGF-1 levels. Elevated IGF-1 acts on a crucial signaling pathway known as mTORC1. When stimulated, this node drastically upregulates sebaceous lipogenesis and forces acroinfundibular keratinocytes to hyperproliferate, clogging the follicle. Tobacco triggers a distinctly different yet equally damaging pathway. Nicotine stimulates acetylcholine receptors in a sebaceous gland. This direct chemical stress causes the peroxidation of squalene within the sebum, rapidly oxidizing and degrading the lipid structure. By directly accelerating the mTORC1 and inflammatory pathways, dietary choices and tobacco use function as precise molecular drivers of the disease pathology. This cellular pathophysiology translates directly into how we manage the disease in a clinical setting, starting with the initial diagnostic intake. This algorithm highlights the critical divergence in laboratory investigation, splitting based on clinical signs of hyperandrogenism. Following the left branch, the vast majority are normal androgenic. Because androgen conversion happens locally, they bypass systemic workups and proceed directly to treatment. The strict exceptions lie on the right branch. If a patient presents with severe clinical markers, like hirsutism, alopecia, or metabolic syndrome, a full endocrine investigation to rule out polycystic ovary syndrome is required. But for the vast majority of AFA patients, withholding targeted acne treatment pending a systemic endocrinology panel is clinical time wasted. Once diagnosed, we move to this comprehensive treatment architecture. The pharmacological intervention must be calibrated to the severity of the localized dysfunction. Standard adolescent treatments will often fail here. Highly concentrated benzoyl peroxide relies on broad-spectrum bactericidal action, which severely strips and exacerbates the already deficient aging epidermal barrier found in adult women. Instead, treatments must target the underlying mechanisms. Oral spironolactone provides precise androgen blockade. It blocks the sebasite receptor directly, circumventing the hyperactive local conversion loop without relying on systemic hormone suppression. On the immune side, topical azelaic acid actively downregulates the expression of toll-like receptor 2. This directly dampens the innate immune cascade, shutting off the release of pro-inflammatory cytokines before matrix degradation occurs. Successful pharmacology for AFA requires the precise interception of these local biochemical loops, rather than relying on barrier-stripping antibacterial agents. Even when acute symptoms subside, the underlying tissue dysfunction remains. If acute systemic treatments are abruptly halted, clinical relapses are virtually guaranteed. This charts the mandatory maintenance treatment branch of the clinical algorithm, designed specifically for adult skin that is highly susceptible to post-inflammatory hyperpigmentation. It is a clinical necessity to transition patients off acute systemic antibiotics and onto barrier-supportive long-term topical therapies. The ultimate clinical endpoint is to achieve sustained modulation of the innate immune response, suppressing the inflammatory cascade without continually degrading the stratum corneum. Managing this localized chronic condition requires a transition away from adolescent protocols, focusing instead on tissue-level intervention and long-term barrier defense.